Thanks very much. I'll take the long minute here. So, believe me, this is the first time I am being born and brought up in Calcutta. Because Amitabh Bachchan has been telling us something or other every year got stuck. So, this time I am here. Okay, this is next around 17-18 minutes. I'm going to talk to you about diabetes and obesity difference. Other than the faculties or the delegates, have you heard a topic like this in any meeting? Any raise in hand? If you tell yes, I'm not going to ask any question. Don't think that. Anybody have? Not the faculties. Okay, that's good. Thank you. Little bit of a pre-on this is so and so. So this is my plan to tell the difference in men and almost women as possible listening. And we are doing a study, so we are going to present some meeting idea. We have submitted some of the data I showed you. And lastly, I'll tell you an online survey the endocrinologists we have done in the last week. Some of these people have replied as well. And I'll be particularly talking about the science, perception, and the real, how it changes. Okay, so this is what I want to be doing, very focused and pinpoint, and this is what I don't want. And this gentleman, who is actually naturalized American physicist, survived 153 years. I like this quotation very much. Before I came to this meeting, I was confused. And after attending, I was still confused on a higher level. So I don't want any of you to leave this room after my talk and thinking you're more confused. We understand this very clearly that global emergency is this. We have heard this. But the question is why women? We know that obesity is higher, mental health issue is more, extra hard. Mother, unborn children, miscarriage, birth defect, GDM, features of diabetes. More women with diabetes diet and more men with diabetes. And the socio-economic challenges here. So if you come to this number, how many numbers of differences do you think there will be there? Roughly? I thought I'll try to see that I try to go from other weeks straight to the. Still, I don't understand how 1 to become 4, or that's what. Then I thought I'll go to more ancient literature. I've seen Guruji 7, and ultimately I think it's 10 differences. So I'm going to tell you the 10 differences, and in between, whatever data or studies are there, I'm going to tell you. First one, prevalence. Worldwide. Okay? This is India. Now, interesting thing is there, if you see, now you may see the graph differences minimum, but these are the millions of people. So, feel around 40, 45, 50, women are in less. You see that? Dark one. Dark one is dark blue women. Gradually it proceeds, it becomes same, and sometimes it becomes a bit more. A very interesting point. And the reason we think that estrogen in the premenopausal time, now don't tell me why, because this is a big Pandora's box opening, as a protective effect on the diabetes. So one of the things is skeletal muscle, hepatic insulin sensitivity, glycine shape, and definite data are there about adenovirus and leptin. You know that adenovirus is a beneficial one. And higher brown adipose tissue. Now coming to our study in this, so we have this data analyzed now around 1100 plus people, which I am going to tell you that. Male or more, age there is nothing much difference. Duration of diabetes we didn't find difference. HbA1c, actually we thought the women will have a worse control, but actually not much different. This is not statistically significant. And the percentage of the people HbA1c 7 or below are actually around 30%, both same. So these are we have included the people who have seen for the first time, they have diabetes at least 1 year, and they're adults. Adults, type 2 diabetes, at least 1 year diabetes we are seeing. That's our inclusion criteria. Second point is that risk factor. The observation shows that higher risk factor burden in women. Now here I told premenopausal less, and here I am talking more pronouncedly of hormonal. This is probably over that related to the GDM. Higher blood pressure, higher weight gain, higher mortality rates. Reasoning, we don't know. Some people suggest 2x chromosome. I don't know exactly what happens. So what we found, the risk factor wise, definitely BMI is more in women. Hypertension is more. This is statistically significant. But hyperlipidemia, to our surprise, is actually same. And duration of diabetes of more than 10 years, you need high risk factor for the complication is a bit definitely is more for you. Gestational diabetes. Observation, prominent independent risk factor. Reasoning, pregnancy may unmask subtle pre-existing metabolic abnormality, particularly people with PCOD, obesity, beta cell activity maybe. Just the recommendation, as you all will be tell you need a sustained glucose control implementation of suitable prevention program. Number 4, again observation, estrogen protective premature menopause has increased risk of diabetes, and HRT we have shown on the study as previous talk that hormone replacement therapy actually delays onset. Testosterone in men, testosterone is a protective. So male with hypogonadism has a problem with that in impaired glucose tolerance, beta cell dysfunction and the PCOD. Point number 5, microvascular complications, diabetic food, higher incidence, higher amputation in women, nephropathy, greater decline, the rate of decline of GFR, RDL, neuropathy, frequent greater neuropathic pain, but nephropathy there is no significant difference reported in the literature. So in our study, we show you the data. Last 12 months, I was not checked up 30% of the people, both same, male and female. GFR less than 16 or same, less than 60, same. Micro or macro albuminuria almost same. Diabetic food is little more as supported with the literature. Next point, macrovascular complication. Women have a higher risk of heart disease. Respond poorly to revascularization procedure. This has been documented, and the proposed mechanism is a smaller caliber of the coronary artery disease. Survived their first attack less than men. Again, this is a epidemiological data, very clear data available. Atypical symptom or more. Higher risk of heart failure, and they need aggressive treatment of the risk factors. Now, this is the data. Now, yellow one is the diabetes and red one is no diabetes. In the men, obviously, the diabetics have more mortality in relative to the cardiovascular mortality. But in women, this gap is much more pronounced. That's what we are trying to do. So, coronary artery disease, the outcome in women is worse. And that's the more important that we need to aggressively treat the risk factor. This is from Southeast Asia mortality due to diabetes. If you see in women, all-cause mortality itself is a bit high. Reasoning, more likely to have advanced atherosclerosis than men at the time of diagnosis. I don't know why, but that's what the proposition. Weight gain can be a factor, higher insulin resistance can be another factor, and subclinical inflammation and increased coagulopathy. This is understandable. This is probably hormonal influences there, and obviously the practically lower medical adherence, particularly in our country, lower medical prescription, which I'm going to come in a moment, is a bit more in. Recommendation: more aggressive intervention is needed in women. That's an year after. Now, in our study, symptomatic CAD is much more common in men. So, this is taking all macrovascular disease. Ejection fraction less than 50% are more in men. Angioplasty or intervention rate are actually same. We obviously can't tell you the mortality data. That's not possible for this. But so for the cerebrovascular disease and the peripheral vascular disease, in this we didn't find much difference in men and women. Number 7 factor, psychosocial risk factor. More likely to impact women. Low educational status, we are talking about more of our country here. Socio-economic, occupational status, less people work, definitely, so income is less. Poor access to health care. more diabetes, distress, that's what I try to mention about the mental health. And higher household income is positive in the prevalence of developed countries. That is quite okay, but most important thing, we need to remember the next point about the resource limitation affects more. So you see the out of the pocket. In India, out of the pocket expenditure for health is very high because our government sponsored health is very big. You see, in comparison to the USA, if you take, or UK, they keep all the money for going to the pub and the football match. They don't spend on the health at all. Or do you spend all money on the health only? The ninth points that we have just heard about the top. This is what some data are available now. NFLD, things of systemic disorder, everything together, every organ you can think of. And that's a multi-pronged treatment, combination therapy. It improves the treatment of NFLD, improves the risk for type 2 diabetes, particularly the pre-menopause. Now we are getting more and more data on this. Strongly and independently incident type of type 2 diabetes, particularly with younger women. So what we are trying to tell, NFLD probably accentuates the biological protection of diabetes in premenopause women. So ultimately we are talking about weight loss. That's important. Weight loss exercise. Women with dysglycemia displays higher probability of having NFLD than men, possibly due to worsening of the metabolic risk factor. And the last point is the treatment. Now these are the observations, not that we will be able to do the reasoning for that. Metformin and sulfonylurea, women are less adult, they get more side effects, hypoglycemia and the gastric side effects. GLP-1 receptor analog, there is greater weight reduction in women, but again side effect is more. Lifestyle modification. Now this is interesting. I believe from the literature what I gather, the benefit in women is less than men. Insulin less frequently meet the target of HbA1c more hypoglycemia. Purposefully I am leaving this SGLT with later because the way the data are coming that if my people with the type 2 diabetes are not on SGLT inhibitor, I really seriously need to answer why not. So it's not what is the indication of SGLT inhibitor. Now the days have come, what is not the not indication, how are you not giving that one? And this is what we have seen this. See, out of these, our cohort, last 1 year we asked the history, obviously it's an historical, of the genital mycotic infection, 26 patients, and female 62 patients. But people who are on SGLT inhibitor, on the 26, 16 are on SGLT inhibitor, and 6 out of 62, 34 on SGLT inhibitor. So as such, the prevalence of GMI is common both in men and women, and women it is more common. But what is surprising is this, 47% of the men and 60% of the women are not on SGLT inhibitor, despite they have at least one of them. Heart failure, that is ejection fraction less than 50%, ASCVD or diabetes, they are not on SGLT inhibitor. And this is true for men, but it is more for women. So this was the gender disparity. Now that's what we are trying to tell. Now this we have done in this x-axis about the number of risk factors, 1, 2, 3, 4, 5, 6. Age more than 60, duration more than 10 years, hypertension, dyslipidemia, ASCVD, diabetic retinopathy, any combination. So you see here more or less people in y-axis not on SGLT inhibitor, more or less is the same. But as you see, I still don't know how to explain this. This is new data we have prepared. That if the risk factors are more, their chance of having SGLT inhibitor are really less, which is very surprising actually. We need really to correct our treatment strategy. People who have 6 risk factors, 80 women, 85% of them are not on SGLT. And as I showed you, the GMI is really not that big. This makes me my last point. This is an online survey done only last week. So basically, we have an endocrine group called Friendos and also one called Cardiac and Endocrine Society. So we have sent the questions of the prevalence and weight as a preparation of that. Then we got some first 100 reply. I have analyzed and I am going to show you this graph. Okay. Thus, I will talk about the science, perception, and reality. So this is the same thing. The first one, this doctor thinks that males more. So if you take an example to understand that, so 38% of doctors think, the endocrinologists think that male have more prevalence, 21% think female have more prevalence, 26% thinks that same, 15% no comment, not sure. Okay, this is the way we need to read this data. So what is interesting I want to highlight is the SGLT inhibitor. See, 51% of the endocrinologists think the male are getting more SGLT inhibitor. 4% think female are getting more SGLT inhibitor. 33% think the same, and 12% is not very sure. And that's what the science, perception, the reality I want to tell. Science, scientific guideline tells that unless proved otherwise, people should be on SGLT inhibitor, type 2 diabetes. Perception is this, what we are thinking. And the reality, as I showed in our data, that very few people, a very big number of people are not getting the benefit of SGLT inhibitor. So it's time to accept. I think Mahadev told that good chicken and साहस चाहिए, बापू ने बोला sorry बोलते कि हिम्मत चाहिए. But I'm very sure you will agree that people who torture Sita and Draupadi are not finished. We are finished and we will also finish the culprits here. So my conclusion and take-home message, diabetes hormone is different, it demands more attention. Screening, early diagnosis, early treatment, and early intervention with this factor. Obesity makes women more vulnerable to diabetes. Our study also showed that BMI is more in women. Heart disease is more common and serious in women with diabetes. We still didn't document very well, but I'm sure this is very clear information in literature. And pharmacological therapy, more attention needed to women. We showed that less use of SGLT inhibitor in women in general, more worrying in women with a multiple risk factor. That's very, very important. So what I expect, and the last point is that pregnancy is an important window of opportunity for better care. We need to make it very sure there is a pre-diabetes condition, and we need to intervene from immediately after from delivery onwards. So what is my expectation from the future research is that we need some gender-specific guideline recommendation, focus on personalization of diabetes management, pharmacological and individualized lifestyle approach. We need to redefine the threshold of treatment to prevent CAD in women, very, very important, and a more acceptable pharmacological option for weight management. That looks a culprit for the time being. Thank you very much.
Thank you.